Hello, dear friends. Hello, esteemed colleagues. Today we will talk about astigmatism. It seems to be quite a clear topic, which indeed it would seem actually poses no difficulty for understanding. In fact, it is straightforward. However, during our conversation today, we will understand and see many different manifestations of this disease that we know little about, as well as the treatment methods that are modern, innovative, and very effective today. Well, to begin with, let's imagine the epidemiology of this disease. As you can see, in countries like China, South Korea, and other countries, also in Europe, this is a common disease, such as the prevalence is higher in some places and lower in others. But it seems to me that this is not so much related to population demographics, as it is probably more connected to the accuracy of research, the volume of studies, the precision of statistical data collection, and so on. Again, regarding the question of epidemiology, well, here in this table, it is also clear that we know that astigmatism can be of low, medium, or high degree. Well, here, both epidemiology and all patients are distributed according to this classification. We see that indeed, again, there are many patients with high degrees of astigmatism in China. Well, I must say that they are indeed quite prevalent everywhere. Actually, here the optics are presented, the optical anomaly, and also what this anomaly entails for the visual system. As we know, astigmatism is a congenital condition, and due to its congenital nature, it carries the losses for the development of the visual analyzer that are associated with underdevelopment and functional underdevelopment of the visual system. The main problem of astigmatism, especially of medium and high degree, is the development of amblyopia. At the same time, I want to say that here is an important point that many do not take into account. The specifics of the development of refractive amblyopia in astigmatism fundamentally differ from that which develops, for example, in anisometropia. In astigmatism, we have a kind of anisometropia within one eye, such as along one meridian, astigmatism in the eye indicates that the image is formed. Further, the receptive fields associated with these areas of the retina are positioned differently. For example, if we take direct astigmatism with hyperopia, it turns out that the fields oriented along the vertical meridian are located closer to the retina than those foci located along the horizontal meridian. As a result, the cortical cells associated with these receptive fields, such as those in various ways, experience different stimulation. It turns out that, in fact, the fields that are associated with the horizontal meridian tend to develop worse in the human brain, in the cerebral cortex, than those related to the vertical meridian. At one time, this condition was called uncorrectable astigmatism, when it seems to be correct, direct, regular astigmatism, but nevertheless is not correctable. It was not something that anyone thought of at the time to assume that this eye had such a specific form of amblyopia. We know for sure that this type of amblyopia exists. In our time, we conducted a lot of research on this topic and effectively proved the existence of this very meridional amblyopia, where amblyopia develops along those meridians, whose focus is further from the retina. As a result, we received a response from the material substrate on this topic, from the visual cortex. The methodology was developed by us, and we proved this through the study of visual evoked potentials. We will also discuss this further below. Well, here is the optics, how optical conoids are formed in regular astigmatism. I think everything is clear here. Just to ensure everything is absolutely clear, I will give you a brief moment to read through this slide, and before we proceed to the next part, let's move on. Well, the classification is well known both physiologically and pathologically. Accordingly, anything above 1 diopter is considered pathological astigmatism. Well, the optimal physiological astigmatism is, of course, astigmatism of 0.75 and 1 diopter. This can also be considered generally non-pathological. Well, regarding the structure that causes astigmatism, of course, the most common are corneal, because, as a rule, astigmatism is associated with improper curvature of the cornea. Well, it can happen that the lens sometimes also makes its adjustments in quotes, and additionally, there are also such astigmatisms. Well, there are, of course, primary, non-congenital, determined, and secondary, related to various corneal diseases. In terms of uniformity, it can be regular and irregular. Here it is shown how refraction occurs in the vertical meridian, that is, in normal conditions. If we are talking about physiological astigmatism, then the vertical meridian must be optically stronger than the horizontal. Reverse astigmatism, when it is the other way around, but there is also a separate version, which is astigmatism with oblique axis, and it also has its own special specifics, both in terms of correction and in terms of the amblyopia that develops later and how this amblyopia should be treated. Depending on the location of the astigmatism foci, it can be myopic, such as simple myopic mixed, or for example, simple hyperopic and complex hyperopic. Well, here is such a slide presented, but of course, complaints that the patient has start from childhood. And I wouldn't really say that a child at 1 year or 1.5 can make such complaints. Nevertheless, yes, astigmatism itself in an adult can also cause asthenopic phenomena. And these asthenopic phenomena can lead to such complaints. Diagnosing astigmatism today is not particularly complicated. If before it was necessary to catch the shadow of the skioscope, when it was done in the skioscope, now this is not needed. Autorefraction gives us a clear picture. For younger people, this can be done using various devices, also remote ones, refractometers, which are very specific for children and can easily be used even for a 6 or 4-month-old child. We never have such problems. Well, with the help of cross cylinders, this is already a technique that allows determining the minimal degrees of astigmatism and is more likely used for selecting correction rather than for diagnosis. Rostlena also allows for a very convenient, inexpensive method of research, does not require the presence of autorefractors, and is very suitable for screening studies, mandatory visometry, of course, and, accordingly, preliminary correction. And please excuse me for such detail, we are soon stopping on the topic. I would like to talk about those routine things that we usually do. Here are some interesting figures. In childhood, 30% of children have astigmatism. At the same time, amblyopia develops in half of them, which is very important. So, what is astigmatism? It is not just some ordinary optical anomaly, but rather a quite serious matter. And this amblyopia, I repeat, is meridional. It is not ordinary, and the treatment of this amblyopia is we will dedicate a few slides to it. And this is the most important thing, managing a patient with astigmatism. We definitely recommend doing, and we always perform, optical coherence tomography to rule out other causes that could reduce vision. And we have gathered such statistics that when we examine patients and make a preliminary diagnosis of amblyopia, well, refractive, for example, or dysbinocular, in 10% of cases we find partial atrophy there on the OCT. So, make sure to perform OCT. It will give you the opportunity to manage these patients more accurately. It should be noted that the study of visual evoked potentials is essential, but not through flash, because the study of flash potentials will not provide you with any information at all, and the study should be done using special patterns. These patterns are either chessboard or, as we suggest in cases of astigmatism, the study of visual evoked potentials through stimulation with stripes of rectangular light intensity profile. This is a very important matter, and only in this way, only with such stimuli in the form of stripes with a rectangular light intensity profile of varying widths, can we diagnose or rule out the presence of meridional amblyopia. This method is very well established here in terms of protection as well, so if anyone is interested, you can come to see, you can learn. We will gladly share this very comprehensive experience. Well, here we show you exactly how and on which patterns it can be done. If the patient has very low vision, we have patterns, reverse chessboard patterns, to stimulate and obtain the visual evoked potential and to assess its latency and amplitude. Here, say that the main thing is to look at the amplitude of the 100 peak. Not P200, not 300, not pure 100, but specifically 100, which shows us the effective response of the visual cells, the cortex of the brain, which we will focus on when assessing the degree of amblyopia, including meridional. The main problem, as I mentioned, is the development of meridional amblyopia in astigmatism. Therefore, it is very important to correct astigmatism in a timely manner. Do not wait 3 years. Do not wait for something else. As soon as astigmatism is detected, after 4 months, correct it. Then frequently perform refraction tests and, if necessary, adjust your correction. However, leaving astigmatism uncorrected is incorrect, as it ultimately leads to the development of amblyopia. This very meridional amblyopia, which is treated in adulthood, can also be quite difficult. Well, here we present other research methods allowing us to understand the condition of the cornea and how to correct it. We have already mentioned that meridional correction, the correction of astigmatism, is important for prevention as well as treatment. Meridional amblyopia is a very important issue. Therefore, we must know everything about astigmatism, everything about the optical anomaly that causes it. And here, in this context, accordingly, topography is an extremely important and crucial method of research as a scientific discipline. If not, it was not often, but sometimes it happens that there is a situation when we do not have any special astigmatism on the cornea, but the patient does. And so it turns out that we must look for the sources of this astigmatism. Lenses are usually where they are found. There may also be some other changes that refractometry responds to. Therefore, such moments also need to be known and taken into account. It is precisely for this reason that we must look at the axial, sagittal, and tangential so-called curvature. In this tutorial, we will explore the process of understanding and effectively utilizing the advanced features of a topographer. There are different topographers, as is known. The main things for astigmatism are determining the presence of regularity and irregularity, identifying the relevant indices, and assessing the presence or absence of keratoconus, and so on. Well, naturally, most often, regular astigmatism is significantly more common. Regular astigmatism is more characteristic of situations where astigmatism is a consequence of certain diseases. Certain diseases lead to the development of astigmatism. In these cases, astigmatism is usually irregular. It can also be a consequence of refractive surgeries. But congenital astigmatism, the one that is most commonly encountered, typically, generally speaking, regular. It is always necessary, of course, to assess both the curvature and the thickness of the cornea when evaluating astigmatism. And determining the point of minimal thickness is also crucially important. Well, the norm, is somewhere more between 500 to 600 microns. This slide presents a story about how to assess regularity in greater detail and depth and significance. This regularity is a smooth transition, and the change in refractive power from one meridian to another should also occur smoothly. Reverse astigmatism is also clear when the power in the horizontal meridian is greater than in the vertical. The rules for determining regularity and regularity are the same. And with oblique axis, here is an example of a topogram with oblique axis. This is how it looks. The feature of astigmatism with oblique axis is that even small degrees of astigmatism require correction. Well, what are the methods of correction? Why are we getting stuck on optics for so long? Because it determines what correction we will choose and how we will correct it. And why do we need this correction? Not only for the patient's good vision, of course, but also the most important thing in this story is to prevent, as we have already mentioned, the development of meridional amblyopia. Well, different treatment methods for patients of childhood age with meridional amblyopia. Well, here, a chest pattern is presented, a reversion pattern. Chest patterns are reversed from black to white, including ophone receptors. And the patient is intrigued by the fact that he must find some defect on the screen. He finds it, but nevertheless, these chest patterns manage to stimulate his visual cortex accordingly while reversing. Well, there are methods of macular stimulation, which are also based on a moving strip. The quintessence of our conversation about treating mesial amblyopia is the special equipment that we have developed, for which we have the corresponding patents. This is a binocular optometric complex that allows us to present specific stimuli to the patient specifically for activating those areas of the visual cortex and stimulating those channels of visual information conduction that are functionally suppressed. That is, first we conduct a diagnosis, understand which channels are suppressed, and which part of the visual cortex is functioning poorly. And with specific stimuli, we excite these areas of the cortex through the eye. It is a very effective method. And if, with the help of various occlusions and other methods, it takes years to treat a patient, then here, within literally 3 to 4 weeks of treatment, we can resolve all issues related to amblyopia, provided that the treatment starts on time. We write it down 4 times, our rehabilitation is accelerated, and most importantly, the effectiveness increases. Well, here is our statistics, data on the effectiveness of treating patients. This very binocular optometric complex. Well, of course, here we also apply other methods. We have also developed special liquid crystal glasses that we can program in a certain way using special software, which we have also developed in order to stimulate the amblyopic eye and occlude the dominant eye. At the same time, we activate the dominant eye at certain intervals to improve perception. For a very short time, for a fraction of a second or for a second, and then it is occluded again. This is for the treatment of amblyopia. These glasses are also used for treating sensory fusion disorders in strabismus, when the patient lacks the ability to merge visual images into a single image. Then we program another application with this software and also very effectively treat these disorders related to the inability to merge images due to oculomotor disturbances. Laser correction of astigmatism is one of my favorite topics. I think we will also discuss it separately. We perform surgeries on children at 6, 5, and 7 years old for astigmatism. Our task, which was set for us a long time ago, 10 years ago, is to ensure that our children go to school without glasses, with good vision. And I want to say that today we have accomplished this task. We are one of the few clinics in the incredible world that can truly do this today, and I speak about it with pride. Well, as you understand now, astigmatism is not just about putting on glasses and diagnosing it. This is quite a serious problem that is associated with the development of amblyopia, which is related to the fact that which can be treated today in such a way as to completely eliminate it even at a young age, both amblyopia and glasses and in general. This is a story that requires more respect and attention. As you know, we have vision therapy, which we demonstrated in the treatment of medical amblyopia. It is very well developed in Bahrain, now at our Crystal Vision Clinic. And today we can treat all types of refractive anomalies, including myopia, hyperopia, and astigmatism, all types of eye movement disorders, strabismus, nystagmus, and other syndromic issues, such as Tourette-Sofa syndrome, Brown syndrome, disorders in cerebral palsy, and so on. All of this means is now available in terms of both therapy and surgery. Therefore, we will be happy if we can be of help to our children in Bahrain. Thank you all for your attention. I was very glad to speak before you. Thank you for the time you dedicated to this, and we are at your service.